Good afternoon, everybody. Welcome to this FB Live. Today we'll be talking about VBAC. So VBAC is an acronym which stands for Vaginal Birth After Cesarean Delivery. I'm Dr. Smrithi D Nayak. I'm a consultant at Aster RV Hospital, JP Nagar, Bangalore.
Hi, I'm Dr. Bhawana Mishra. I'm a senior consultant in the Department of Obstetrics and Gynecology at Aster RV. We are going to talk about something which which really needs a lot of clarification. So, regarding patient information, we will keep it simple. We will keep it, useful for the common people who are watching us. Now to start with,
So we wanted to know. The reason we chose this topic is a lot of patients come to our OPD who've had a cesarean section, and they want to know what is their chance of having a normal delivery. And the whole dictum which goes once a cesarean, always a cesarean is not always true. We do know that a lot of our patients have had that desire to have a normal delivery, and we have fulfilled it also by helping them out through this journey. So to start off with, let's understand the term VBAC. What does VBAC stand for?
Yeah, VBAC is an acronym for Vaginal Birth After Cesarean. So this is for someone who's had her previous delivery through a cesarean cut. So we know cesarean surgery, it's a surgery wherein the skin and the various other layers and most importantly the uterus is also cut open in order to deliver the child. Now so very often we try and see if such a delivery is possible. So nowadays, other than VBAC, we also have another acronym to say trial of labor after cesarean, which is TOLAC. So why do we look at it at all? What's the importance of having a vaginal birth after a cesarean? So we know that whatever said and done, cesarean is a surgery. You need longer stay in the hospital. You need longer time to recover. Whereas a normal delivery or a vaginal delivery puts you back to your normal status very quickly. Your hospital stay is reduced. The amount of blood that you've lost, during cesarean is much more compared to that of a normal. And then likewise, you regain your health back also very quickly. The chances of infection and all other post-operative things are lesser with a normal delivery. Now, having said that, we also need to know that there are only a few patients who can actually successfully go through a VBAC. So I want Dr. Smrithi to tell us, how do we select our patients for a VBAC?
Yes, so that's a very important and very good question. We need to understand what are the ways in which we actually segregate our patients to even counsel them about a VBAC. Now, having said that, many patients just want to go for a C-section because it's sort of like the easy way out. But we also try to encourage our patients by educating them about whether they fall into the more possible strata of patients who are going to have a successful VBAC. So 3 points here is, one is what was the reason for the previous cesarean section. So if there are different indications which we'll talk about later, if it's a non-recurring indication, they are definitely good candidates for a VBAC. Also, the previous cesarean section, the type of cesarean section done is a very important factor. There are different types, and there is one particular cesarean section where an inverted T-shaped incision is put. Now, this sort of weakens the uterus a lot more than the normal transverse scar. So, when there is this type of a scar, again the chances of, we don't select such patients because we know that the chance of uterine rupture is a lot more. Apart from that, if they've had previous number of cesarean sections, if it's just one, again the chances of scar rupture is lesser. But if they've had 2 previous cesareans or 3 previous cesareans, or for any other reason have had multiple surgeries on the uterus because of which the uterus has been cut open, then again their chances of scar dehiscence increases. So these are the indications, or these are the ways in which we select the patients. But there are certain contraindications for which we should not at all, think of such patients at all. And so Dr. Bhawana will just explain to us what are the contraindications.
Just to sum up where Dr. Smrithi stopped, is the first thing would be, how was the previous cesarean done? Was it a normal horizontal cut on the uterus, on the lower segment of the uterus, or for some reason was it extended? So like an inverted T-shaped incision, or if she's had any previous surgeries on her uterus, say for big fibroids, so or even sometimes uterine malformation, wherein you have cut through the uterus, and so the scar is not strong enough to withstand a vaginal birth later on. That will be the first thing. This present pregnancy, if the child is overtly big, it's a macrosomic baby, or if it's a post-dated pregnancy, wherein already 40 weeks have gone by. So these are the times when we'll not attempt a vaginal birth. Also, if previously during her first cesarean, she's had infection post-operatively and the wound was not very healthy. So such wounds are more liable to rupture this time. So these are basically the contraindication. Also, if there is any associated medical problem with the present pregnancy, like say pregnancy-induced hypertension, or gestational diabetes, or any such things, or other such comorbidities, then we will also want to see if she has a cardiac problem. Then we will not look at a repeat
vaginal birth. Yeah.
And then what do you think increases the chances of a VBAC?
Yes. So patients who have had a previous normal delivery, right? So if they've had a nice successful normal delivery, they actually stand the best chance. And a patient
one cesarean and then following that
a normal delivery, and then of course that would be a previous VBAC itself, right? So a previous VBAC or a previous successful vaginal delivery itself puts them into a good success rate of VBAC. And if they get spontaneous labor pains, after term, we prefer not to induce patients into labor, because spontaneous labor means yes, the baby is ready to come out. The uterus is actually indicating to you that it is ready to deliver the baby. So spontaneous onset of labor pains is very good indicator that it will be a successful VBAC. That is why we encourage a lot of our patients to be very active all throughout pregnancy. It's not at all indicated that you to be at rest, or if you to be cautious about certain exercises. You can always ask us, and we are more than happy to inform you about what all tips we can give you to increase your chances of a vaginal birth. Apart from that, in the labor also, if you have a favorable cervix is the opening of the uterus. That is what we usually assess when we do a vaginal examination, to see if the cervix is dilating at the appropriate, the amount that it should dilate. So favorable cervical score, we actually have a certain way in which we assess the cervix. A favorable score indicates that the patient will have a successful VBAC. Of course, other than that, the non-recurring indications, like you would have had a previous cesarean for umpteen number of reasons. You will have it for fetal distress. If there is meconium stain, that means the color around the baby, the water color becomes greenish, because of which it indicates that the baby has passed motion, and that is an indicator for doing a C-section. Or if there is a breach means that the baby's legs were down and that was the presenting part, and the head was up, and it's very difficult to have a normal delivery in such cases. Or if it's a placenta previa or a low-lying placenta, because of which again chance of normal delivery were low, but not necessarily this will again recur in the second pregnancy. Apart from this, there are other indications like non-progression of labor, cervical dystocia. These are all reasons for which you would have had a C-section in the first pregnancy, but not necessarily in the second pregnancy. These won't recur always. So there's always a good chance, especially spontaneous labor, I would say, is a very good indicator to have a successful VBAC. We tend not to induce labor for such patients. Even, then we have done successful VBACs with very mild induction for some of our patients, where it is very favorable and they've not gone into spontaneous labor, so we don't really just go do a C-section for them. So having said all of these, successful, these points which indicate that they will have a successful VBAC, what are the reasons because of which the success may reduce?
Yeah, right. So if, the patient is rather aged, she is an elderly patient, or she is obese, her body mass index is much high, or if she's that of a very short stature. Yeah. So these are the things where we think that the success rate is going to be less. The baby wise, if the baby is too big, or again if it's a post-dated pregnancy wherein she's completed her 40 weeks of pregnancy, than to try for it, because the baby tends to grow bigger and the water around the baby keeps reducing. So all these will reduce the chances of normal delivery. So, the most important thing which I think I would want to reiterate here is that the patient has to come in a very flexible state of mind. So we know that the way we monitor patient for VBAC and than someone who's having a normal delivery for the first time, maybe a vaginal delivery, is very different. We need to be very, very vigilant while we conduct the VBAC. But at some point, if we think that something is going wrong, one of those monitors are indicating that there is some sign of some kind of a serious issue that is coming up, then you need to be in a flexible mindset to choose a cesarean delivery if the trial of labor is failed. That is important to know. So then what is the risk? Why is a vaginal birth after a cesarean risky at all?
Yes. So there is always a chance of the scar rupture. This in simple terms just means that the cut which was put on the uterus for the previous cesarean gives way, right? And that sort of puts the whole situation in a very high risk sort of situation, because of which the mother can bleed internally and the baby also can have mortality because the blood supply suddenly gets cut off. And we need to detect this as early as possible and then rush the patient to the emergency delivery to do a repeat C-section. That is the reason, as Madam already mentioned, we need to be monitored. A patient in labor who's had a previous cesarean needs to be in a multidisciplinary unit where a lot of consultants will be round the clock and they will be monitoring for any signs of scar rupture.
That's very important.
Yeah, where we're not just going to come once in a day, just see, okay, you're in labor, your dilatation is this much, and then go off. You will need to be supervised continuously by a proper high risk obstetric team. And that is the reason we have done so many of VBACs in Aster RV hospital, and we encourage patients to go for it. And like how Madam said, we cannot guarantee anything. At the end of the day, we have to give it 100% try, but we cannot always say 100% you will deliver normally. Because at the end of the day, our intention is to have a healthy mother and a healthy baby. The route of delivery is secondary, because we do not want to give a compromised mother or a baby just for the sake of achieving a normal delivery. So uterine rupture is a very important and the most difficult complication.
So what after uterine rupture, does it lead to something else? There is increased risk of sometimes even removal of uterus.
Yes,
it comes to that. So you cannot have any more pregnancies.
Correct. So if there is something, the patient has bled a lot and we're not able to salvage the uterus, they may end up even losing their uterus. Though the incidence of this is very low, okay, it can happen in around 1 in 1,000 or 2 in 1,000 deliveries, as long as monitoring is done correctly. So along with this, the other complications are blood transfusion requirement. They may require massive blood transfusion, and during the surgery there can be injury to other adjacent structures, bowel, bladder. All such things can be encountered when the patient is rushed to the emergency after a scar rupture. But that is the most important complication that we are trying to avert here. And more important than this is the patient should understand that this risk involves both mother and the baby. Right. When they understand that, they're very keen on having a normal delivery, but when we explain all this, they take a step back. But we also encourage them and make them understand that we'll be there all throughout with them in the journey. So at any point of time, if we feel the scar is giving way, there are certain indicators we check for in the patient. At any point of time, if you feel there is even the slightest indication that something is not going according to the plan, we take them up for a C-section. So after this,
so what are the symptoms of scar dehiscence? That is also important. When you come to about the 8th month and you constantly have a cramping sensation in your lower belly, or if you feel like you have increased frequency of passing urine, with those cramps you feel like passing urine. Sometimes your urine is blood stained. These go to say that the scar may be giving way and you're not comfortable sitting, lying down, and it is then that we also try to check the scar integrity on our scans, and we see how good is the previous scar. So depending on patient selection, we subject them to a vaginal birth to decide the problem.
Yeah. So just to understand, what are the tips you can give for a person in the antenatal period to sort of prepare themselves for
again, like you
VBAC?
said, a vaginal birth will involve a lot of physical fitness. So we have specially designed exercises and yoga classes where that helps you into, and the most important thing I believe is I feel is the mental motivation for you to believe that as a woman, it is so inherent in you to deliver vaginally. The first time, like we were talking about this particular situation wherein the placenta is low set, or say if the baby was too big or the water was too little, that you not had a normal delivery, but to believe that you can go through it and do it, and of course under good supervision, wherein we check for all your possible risks of a scar or dehiscence or rupture. So we select your thing, and then you are in this flexible frame of mind wherein you are ready to listen to us. Say, God forbid, we cannot give you a vaginal delivery, then you resort to a thing. Also, I wanted to, because we don't have this thing of very large families now, it's mostly 2 or max 3 nowadays. So, say if you're contemplating to have a family planning surgeries also with your repeat cesarean, then I think, instead of trying for all this vaginal birth, you can straight away have a repeat cesarean and, the family planning surgery also done together. Of course, we leave the choice to you, but to tell you that, about 6 to 8 people out of every 10 people who had a cesarean can actually have a VBAC.
So one of the things I just wanted to mention is during labor also, taking an epidural is very important, and there are certain myths that people have against epidural, that I don't want my pain analgesia, but believe me, when you're trying for a VBAC, epidural really helps in relieving the pain and tolerating the pain, because maybe in the first pregnancy you would have had a direct C-section without really experiencing labor pains. So in the second pregnancy, when you come for a VBAC and you start experiencing labor pains, it becomes like too much to take, and then you immediately start saying, listen doctor, let me just go for the C-section. That's not very good. So going for an epidural is very important. Understanding the labor analgesia, it's called painless labor, but it's not truly 100% painless. Please understand the pain intensity reduces by up to 50-60%. Patients are like, I still have pain, so what is this? Why isn't it completely painless? That's not true. It's called painless labor, but then, the appropriate way of doing it is to reduce the intensity to a certain extent, so that the patient still has a little bit of a sensation, but they are, they can go through that time when they're around 3 centimeters to at least up to 10 centimeters, and then when they're 10 and that urge to push is required, we actually end up stopping the epidural so that they push out the baby with the proper strength that they require.
Correct. So to conclude that that there's this myth going on that once a cesarean always a cesarean is not true. Wherein when we choose our patients very judiciously, we can have them experience a vaginal birth also after cesarean, but to listen to your doctor and to get ready for it well in advance will always help.
Correct.
I think
and lastly, I'd like to say that you have to choose the best hospital with all the facilities available for the vaginal birth to be a success, like a blood bank, the requirement of blood may be there anytime, requirement of an OT immediately, the anesthetist round the clock, pediatrician round the clock. So choose the team that you want to deliver with very wisely. And here at Aster RB, we work as a team where, like I already mentioned, we're always there round the clock. At least one consultant will be there to monitor the patient who's in VBAC, because we don't take it lightly. We really want to give a successful VBAC, and we know the reasons why it may land up in trouble, so we don't want to take any chances. So choose the team that you deliver with a lot of judiciously, and of course please leave your comments or any other questions you have in the comment section below, and we'll be more than happy to get back to you with the answers. Thank you so much for watching.
Thanks.
Thank you.